Hi everybody. Tonight I'm going to talk about inflammation and infection, and then for the second half of the lecture, the pharmacology for infection. The first part of the lecture is partly a review from fundamentals, and it's going to go pretty quickly. First of all, inflammation versus infection. Inflammation is a non-specific response to an injury, regardless of the cause. Inflammation can be caused by many things, not just a pathogen or microorganism. For example, inflammation can be caused by surgical incisions, burns, strokes, heart attacks, and immune reactions. Infection, on the other hand, is a specific inflammatory response to a pathogen or microorganism that invades the body. Inflammation is a protective response to destroy the harmful agent, limit the spread to other tissues, and initiate the healing process. Whatever the cause of the inflammation, the sequence of events involved in the inflammatory response will always be the same. First, there's a vascular response, then a cellular response, followed by tissue healing and repair. In other words, if we're talking about the inflammatory process with a stroke or the inflammatory process with a microorganism, the sequence of events is going to be exactly the same. Let's quickly review the inflammatory process, which is the body's attempt to limit, destroy the cause of the inflammation, and begin the healing process. First of all is the vascular response, where the blood vessels around the injured area dilate and the body releases chemicals that cause this. These chemicals are histamine and prostaglandin. Remember those two chemicals. This leads to an increased blood flow to the area, which causes redness and warmth. The capillaries leak fluid into the surrounding tissue, which causes edema. And the chemical mediators in the edema cause pain and impaired function in the area. The amount of pain depends on the amount of prostaglandin released. So the prostaglandin is the chemical that is responsible for the pain reaction. The cellular response, the blood flow increases to the impaired tissue, and it causes white blood cells to rush into the area to try to destroy the harmful bacteria. And then there's the healing or tissue repair response. Healing, the inflammatory process restores normal structure and function, and the tissue regenerates. Tissue repair occurs if regeneration is not possible, and scar tissue replaces the destroyed tissue. Scar tissue is weaker than the original tissue, so it is more vulnerable to re-injury. So, the local manifestations are redness, warmth, edema, pain, and loss of function, which are all because of the vascular response where the blood vessels dilate. Then there's purulent drainage, and that is from the cellular level. Remember, the more extensive the tissue damage, the greater the pain, swelling, and loss of function. Systemically, things occur within the body away from the local site of the tissue damage. That would be your fatigue, enlarged lymph nodes, loss of appetite, elevated heart rate, respirations, and temperature. And the white blood cell count is over 10,000, which is a sign that there is infection. Inflammation can be acute or chronic. Acute inflammation is a short-term reaction by the body to any tissue damage. When the harmful agent is removed, the inflammation ceases to exist. It lasts less than 1 hour and up to 2 weeks. And again, remember, it's the amount of prostaglandin release that determines if the pain is mild or severe. A chronic inflammation develops more slowly and may last for weeks, months, or even years. Chronic inflammation results when the inflammation does not effectively resolve or if there's constant repeated exposure to the irritant. An example of a chronic infection would be tuberculosis, where the bacteria can live dormant in the body for years and only cause symptoms if the immune system is compromised. Remember the chain of infection? In order for an infection to take place, 6 key elements must be present at the same time. The first is the infectious agent. In this case, because we're mostly talking about infection, we're going to call that the microorganism. In order for disease to result, the microorganism must be virulent and invasive. Virulence refers to the number of microorganisms, the type of microorganisms, and the health of the host. Invasiveness is the microorganism's ability to invade and multiply, resisting the host defenses and producing toxins. The reservoir is where the pathogens live and grow, and that would be the human body. Port of exit is the way the microorganisms get out of the host. So you could sneeze and cough, it gets out of you by the respiratory system. Vomiting, diarrhea, or feces would be the GI system, and so forth. The mode of transmission, just remember from fundamentals: direct contact, indirect contact, droplet, airborne, or vector. Vectors are insects and animals. The port of entry is the way it gets into the host, and the way it gets into the host is the same way it got out of the host. And then you need a susceptible host. A person can resist infection with their physical barriers, such as intact skin, hostile environment in their internal organs. Coughing and sneezing helps expel the pathogens. The white blood cells help. However, a host becomes more susceptible when certain invasive procedures take place, like catheters and IVs, the very young of age and the very old of age, and patients with compromised immune systems are more susceptible to infection. And just remember, all microorganisms, including non-pathogens, are capable of contributing to disease under the certain correct circumstances. That would be what we call a superinfection, like C. diff, and we'll get to that a little later. The stages of infections vary quickly. You have the initial stage where the microorganism incubates, the prodromal stage where the early symptoms, the vague symptoms start to appear, like maybe fever, muscle aches. The acute stage, where the pathogen is reproducing rapidly and is colonized. The signs and symptoms become more obvious and specific. A sore throat with strep throat, for example. Then there's the convalescent stage. The infection is contained, the pathogens are dying, and the symptoms begin to disappear. And the resolution stage, the infection is totally eliminated. Remember, people with chronic infection never reach the convalescent stage or resolution stage. There are common microorganisms that cause infection. The first being bacteria. Bacteria are single-cell microorganisms that can be seen under a microscope. Bacterial infections are treated with antibiotics. Antibiotics only work against bacteria. Bacteria are classified by the gram stain. A bacteria is either going to stain gram positive or gram negative. You probably know from microbiology that a stain is applied to a specimen of the bacteria. If the bacteria stains blackish purple, it's gram-positive. If it stains pinkish red, it's gram-negative. Bacteria is also categorized by its shape. There's cocci, bacilli, and spirochetes. Cocci are round. That would be your staph and strep. Bacilli are rod-shaped, like E. coli. And spirochetes are long and slender. There is a picture at the back of the packet on gram stains. The second thing that causes infection are viruses. Viruses are very, very small, much smaller than bacteria, and they can only be seen with a high-powered microscope. They do not respond to antibiotics, but there are some antiviral agents. And vaccinations give you immunity to certain viruses like Hep B, measles, mumps, and rubella, things like that. Fungi are yeasts and molds, and we have antifungals for those. Rickettsia are parasites that live outside the body like lice, ticks, and fleas. And helminths are infectious worms. The next thing I want to talk about is MDROs, or multi-drug resistant organisms. At the back of the packet are fact sheets on MRSA, VRE, and C. diff. MRSA means methicillin-resistant Staphylococcus aureus. Methicillin is a type of penicillin that ordinarily kills the bacteria Staphylococcus. As the bacteria grows harder or mutates, they resist the effects of methicillin and it doesn't work. So that's why it's called MRSA, because it resists the drug that initially could kill it, and other drugs have to be used. Staph A grows harmlessly in your nose and on your body. If a staph infection is resistant to methicillin, it's usually treated with vancomycin, and the person is on contact precautions. ORSA, if you ever see that term, ORSA, means oxacillin-resistant Staph aureus. It's exactly the same thing as methicillin-resistant Staph aureus, except here we're referring to the antibiotic oxacillin, which is another type of penicillin that ordinarily kills it. VRSA is vancomycin-resistant Staphylococcus aureus, and then VRSA is treated with other antibiotics, but the fear in the medical community is that a totally antibiotic-resistant strain of Staph A is going to emerge. And VRE is vancomycin-resistant Enterococcus. Enterococcus is just another round-shaped bacteria. It grows in the normal flora of the GI tract and in the female genital tract. Because of the overuse of antibiotics, specifically vancomycin, the Enterococcus has developed and reproduced beyond healthy numbers, even when vancomycin is used. Vancomycin is the drug of choice to treat all enterococcal infections, but if the strain is resistant to vancomycin, it is treated with another antibiotic that you don't see too often, which is very potent, is Vioxx. C. diff, Clostridium difficile-associated diarrhea. C. diff is a gram-positive bacteria, and the main symptom, which I think you all know, is diarrhea. Diarrhea can be mild, but it can also be severe and life-threatening. C. diff grows in the digestive tract, but because the normal flora of the digestive tract is there with good bacteria, it keeps C. diff from growing out of control. Antibiotic therapy antibiotics work, but they're not smart. So they can't tell the good bacteria from the bad bacteria. So when you're taking an antibiotic, it also destroys the good bacteria in the gut. And that's what allows C. diff to grow uncontrollably. C. diff is treated with Flagyl or vancomycin. You remember with C. diff, spores can live outside the body on surfaces in the environment for months. C. diff is a superinfection. Remember, alcohol-based hand rubs will not kill C. diff. And the last one I want to talk about is ESBL, extended spectrum beta lactamase. A microorganism becomes resistant to third generation cephalosporins, which I'm going to tell you about soon. And then they no longer destroy this bacteria. ESBL is often found in the urinary tract of patients who have been catheterized and in gastrostomies. And again, all of these things that I just mentioned, the person will be on contact precautions. The interdisciplinary care with a person with an infection, the lab results you're going to look at are a white blood cell count that's going to be elevated. The ESR, or the erythrocyte sed rate, will be elevated. It just indicates a generalized infection. CRP, or C-reactive protein, produced in the liver. A positive CRP indicates inflammation. And then what's important for this lecture, when we get into talking about antibiotics, is the culture and sensitivity. So what we do is we take a swab of the infected site, and it's cultured in a petri dish. If the infection agent is bacterial, it's going to stain gram-positive or negative. Then there's the culture and sensitivity. This is important for our lecture tonight when we talk about the anti-infective medication. With the culture and sensitivity, a swab is done of the infected site, and it's cultured in a petri dish. If the infectious agent is bacterial, it'll stain gram-positive or negative. Then you put antibiotic discs on top of it that have various antibiotics. And you wait a while, however many hours, 24 hours, let's say, and then they look at the petri dish with the disc of antibiotics, and they can see which antibiotics the bacteria is sensitive to. So they can see which antibiotics were effective against that bacteria. There's medications we're going to talk about. I want to mention quickly here Ray's syndrome. Ray's syndrome is seen in children under 15 after an acute viral infection like chickenpox or influenza. Ray's syndrome causes increased intracranial pressure, so your brain swells, and that can lead to seizure. The symptoms occur about 1 week after a viral infection. The signs and symptoms are severe nausea, vomiting, changes in mental status, which is agitation, seizures, and it can lead to coma. The cause is unknown, but there's a very strong association with the use of aspirin and aspirin-related products to reduce the fever in a child during an acute viral attack. Never give aspirin to children under 15 when they're sick. Then there's a fever. You know that a fever is the body's way of helping to prevent infection, so you don't want to give aspirin or products like that for temperatures under 102. Of course, wound care, rest, increasing fluids, and a well-balanced diet Monitor the vital signs, monitor pain, and always use aseptic technique. I quickly put in the lecture, things you need to teach patients and family to prevent and treat infection. So hand washing, using disposable tissue, avoiding crowds if you're ill or immunocompromised, not sharing personal items like your razor and toothbrush, safe sex, safe food handling, using a 1 to 10 bleach solution when you're cleaning because it kills microorganisms, keep your immunizations updated, take anti-infective meds as prescribed. This is really important for the full course of treatment. Follow the special instructions when you're taking anti-infective meds, like when to take it. Do you take it with food or without food? Do you need to take water, etc.? Know your side effects of meds. Never share meds. Person should wear med alert bracelets if they're allergic to any anti-infective meds. Have yearly flu and pneumonia shots. Adequate nutrition. Notify your provider about signs and symptoms of infection. And for people that are immune suppressed, avoid eating unskinned, uncooked foods and vegetables. Avoid crowds. And teach family members with infections to stay away from people that are immune suppressed. That concludes the general review of infection. We'll take a little break and then we'll do the anti-infectives. Anti-infectives. Anti-infectives are medications that treat infection. An infection may be caused by bacteria, virus, fungus, parasites, or helminths. The main focus of this lecture is antibiotics, which are medications used to treat bacterial infections. We'll also touch briefly upon the medications to treat viruses, fungi, helminths, and parasites. This lecture can be intense and overwhelming. It's hard to learn about new medication, but I'll try to keep it in perspective. I want you to take away from this lecture the basic concepts, the major side effects associated with this potentially yet life-saving medications, and the special considerations involved around specific meds. Prior to the discovery of antibiotics, people were dying of bacterial infections such as syphilis, gonorrhea, and tuberculosis. Prior to the advent of vaccines, contracting viral diseases such as Hep B, Hep C, and polio were commonplace and not treatable. Before antivirals were perfected, people diagnosed with viruses such as HIV were not living long. So we have come a long way in treating infections. Antibiotics, and you probably want to follow along in your farm book. There are 6 categories of antibiotics, plus the anti-TB and anti-leprosy meds. We're not going to talk about the anti-leprosy and TB meds tonight. That'll be later. Don't get confused by all this. All of these drugs are antibiotic, and they all work against bacteria. However, their chemical composition is different, and some work better than others for certain infections. In addition, a person may be allergic to one group and need to take a medication from a different group. Some antibiotics are more effective on gram-positive organisms. Some are more effective on gram-negative organisms. Those are called narrow-spectrum antibiotics. Still, other antibiotics are equally effective against gram-positive and gram-negative microorganisms and are known as broad-spectrum antibiotics. Each group acts differently at a cellular level to attack the bacteria. An antibiotic can be bacteriostatic or it can be bacteriocytic. Bacteriostatic antibiotics reduce the growth of microorganisms. They don't eliminate them, they reduce the growth. But once the rate of bacteria multiplication slows, the body's own white blood cells are able to rid the body of the microorganism and control the infection. Bactericidal antibiotics destroy the microorganism. So bacteriocytic or cidal, like homicide, suicide, bactericide. Cide is the act of killing. The antibiotic of choice is the one most likely to interfere with the bacteria and least likely to cause toxicity and allergic reaction. A culture and sensitivity will show which antibiotics will be effective against an organism. The patient will probably be put on a broad spectrum antibiotic until the results of the culture and sensitivity are back. After the CNS results are confirmed, the antibiotic will be changed the most effective, least toxic med. Deciding on the best antibiotic for the patient is based on the location and severity of the infection, the patient's age and weight, the general health of the patient, and pre-existing medical conditions like pregnancy, drug interactions, allergies, and side effects. Side effects and adverse reactions. Antibiotics can cause many side effects and adverse reactions. When we talk about the specific categories of antibiotics, I will talk about the specific side effects. But right now, I wanted to find and explain some of the common problems that occur with all antibiotics. First is GI symptoms, such as nausea, vomiting, and diarrhea. GI symptoms are common with all antibiotics. This is a side effect, not an adverse reaction. Doesn't mean you're allergic to it. Photosensitivity also occurs with some antibiotics, many of them. The person becomes overly sensitive to being in the sunlight or ultraviolet light, and an exaggerated sunburn reaction occurs, and the person is prone to dermatitis. Both of these things, the GI symptoms and the photosensitivity, are side effects, and they will disappear when the med is finished. The third thing are toxicities. These are specific to certain antibiotics, and you should know which ones, and you will, I hope, after the end of this lecture. The first toxicity is ototoxicity. The medication, OTO, is your ear, so the medication is harmful to the ear. Deafness may result. The signs and symptoms of ototoxicity are tinnitus, which is ringing in your ear, dizziness, a roaring sound in the ear, vertigo, and mild to severe hearing loss. The next toxicity is nephrotoxicity. Nephro means kidney. So the medication is harmful or toxic to the kidneys, and kidney failure may result. The signs and symptoms of nephrotoxicity are protein in the urine, or proteinuria, hematuria, blood in the urine, an increased BUN, an increased serum creatinine level, and a decreased urine output. The next toxicity is hepatotoxicity. Hepato means liver. So these medications are harmful to the liver, and liver failure may result. Signs and symptoms of this are anorexia, nausea, vomiting, right upper abdominal pain, jaundice, itching, clay-colored stools, and dark urine. The next toxicity, or the last one that I want to mention, is neurotoxicity. Therefore, you know the medication is harmful to the nervous system, and brain damage may result. The signs and symptoms of neurotoxicity are numbness, skin tingling, circumoral paresthesia, which is around the mouth, feels numb and tingling, tremors, muscle twitching, convulsions or seizures, muscle weakness, and a neuromuscular blockade can occur, which is an acute muscular paralysis, including paralysis of the respiratory muscles and difficulty breathing. So all of these toxicities are very severe, and you've got to monitor closely for them. An allergic reaction is a hypersensitivity to the antibiotics that can lead to a life-threatening allergic reactions. All antibiotics can cause Stevens-Johnson syndrome and or an anaphylactic reaction or anaphylactic shock. First reaction is Stevens-Johnson syndrome. First reaction is Stevens-Johnson syndrome. It's a serious, sometimes fatal hypersensitivity reaction. It begins with vague signs and symptoms like the flu, generalized aches and pains, maybe a fever, and it's characterized by lesions on the skin and mucous membrane. Specifically, the lesions are prevalent on the face, around the lips, the mouth, and the eyes and neck. The lesions may also appear on the extremities, but it's the facial area where you see it most prevalently. The lesions appear as red welts like blisters or urticaria, which would be hives. And so it's a generalized skin eruption. The lesions are extremely itchy, and skin loss can occur. As the syndrome progresses, it'll lead to infection and dehydration. If Stevens-Johnson syndrome occurs, discontinue the medication immediately and notify the doctor. And there is a picture of that in your packet. An anaphylactic shock is an extremely serious allergic drug reaction that usually occurs shortly after the start of antibiotic therapy. A generalized rash appears on the skin, markedly the whole trunk and extremities. The person has urticaria, which is hives, pruritus and itching, diaphoresis, which is increased perspiration, redness, edema, and warmth. The next thing that happens is called angioedema. A collection of fluids in the subcutaneous tissue leads to edema or swelling of the eyelids, the lips, the mouth, and the throat. Angioedema of the mouth and throat can block the airway, and asphyxia can occur. In the cardiovascular system, the blood pressure plummets. The person has an extremely fast heart rate, over 100, heart palpitations, syncope or fainting, and cardiac arrest can occur. In the respiratory system, there's bronchospasm, dyspnea, the person can't breathe, coughing, wheezing, tightness in the throat, and again, asphyxia. If you're administering an IM antibiotic, the person should wait 30 minutes before leaving the office or the area so that you can observe them, because the antibiotic given IM, the allergic reaction may take a little longer. But if a reaction, an allergic reaction causing anaphylactic shock occurs to any antibiotic, discontinue the medication immediately, notify the doctor, and the patient should never take this antibiotic again. And then we talked a little bit about it earlier, but superinfections, The natural flora, or the good bacteria, is reduced by the antibiotic, which allows the bad bacteria to take over and multiply. That would be an example is C. diff. And remember, all antibiotics can cause superinfections. The nursing implication for any antibiotic is number 1, take the medication at the prescribed time intervals. These time intervals are important in order to maintain a constant, consistent amount of the drug in the body at all times. So you want the drug in the body constantly through 24 hours of the day. So perhaps it would be ordered 6 a.m., 12 noon, 6 p.m., and 12 midnight. Do not omit or skip a dose. Never share antibiotics. Don't share any meds, of course. Complete the entire course of therapy. This happens all the time. The person thinks they feel better. They stop taking the medication, and the symptoms have disappeared. What happens is failure to take the full course of the medication allows the bacteria that's left to start remultiplying, and the infection returns. Always monitor the person closely for signs and symptoms of hypersensitivity and allergic reactions such as Stevens-Johnson syndrome or anaphylactic shock. If the symptoms occur, discontinue the med and notify the PCP. Monitor for signs and symptoms of toxicity, and if you notice anything, let the doctor know ASAP. And monitor for signs and symptoms of superinfection. Again, let the doctor know. Now let's talk about specific antibiotics. Remember, there's 6 classes of antibiotics that we're going to talk about tonight, plus the anti-TB and anti-leprosy antibiotics that we'll talk about in a different time period. The categories are based on the chemicals the categories are based on chemical composition and mode of action. The categories of antibiotics are the sulfonamides, the penicillins, the cephalosporins, the tetracyclines, macrolides, and lincosamides. Those are all one group. The fluoroquinolones and the aminoglycosides, that's the 5th group. Then there's a group of singular drugs that aren't in any of these categories. And lastly, anti-leprosy and anti-TB meds. The first antibiotic we're going to talk about, the first group, is the sulfonamides, which are the sulfa drugs. The sulfonamides or sulfa drugs were the first antibiotic discovered. The sulfonamides are bacteriostatic. Remember, that means they reduce the multiplication of bacteria, so the body's own defenses, the white blood cells, can come in and do their job and destroy what's left. The sulfa drugs are not widely used since the discovery of the other antibiotics. Nonetheless, they're very effective for the treatment of certain infections. Most of the generic names for sulfonamides contain the prefix sulfa or sulfi. They're used commonly for urinary tract infections, burns, ear infections, and one drug, sulfasalazine, is used for ulcerative colitis. The side effects of sulfa drugs are GI symptoms, like we talked about in the beginning. They also have hematological symptoms. They lower the platelet count, the red blood cell count, and the white blood cell count. Photosensitivity, altered or low urinary output and crystals in the urine. Like all antibiotics, they can cause Stevens-Johnson's and anaphylaxis, and superinfections. Sulfonamides increase the risk of hypoglycemia or low blood sugar, especially in a diabetic patient. And sulfonamides increase the effect of anticoagulant medication. So if you were on an anticoagulant, it would become more potent when you're on a sulfonamide. I gave you some examples of, I gave you 4 examples of sulfa medication. The first one, and notice the prefix in the beginning, the first one is sulfisoxazone or gantracin. They use that for UTIs. So I have some examples here of the sulfonamides. You'll see them in your pharmacy text. I gave you 4 examples. There's many, many more. The first one, what I want you to notice too, is all of these have the suffix SULFI or SULFA. So the first one is gantracin. The next one is a combination drug with an anti-infective, a sulfa drug, plus a urinary analgesic like Bactrim or Septrim. So they also treat urinary tract infections. The third one, sulfasalazine, has some special considerations that you should remember. What it does, it turns the skin and the urine an orange-yellow color. Not always, but it may. This is not abnormal, and it's going to disappear when the med is discontinued. If the person wears contact lenses, they probably will not want to be wearing them while they're on this medication, but it may cause the soft contact lenses to develop a permanent yellowish stain. So probably go back to the old glasses while you're on that. The last one I'm mentioning is silver sulfadiazine or Silvadine. You may have heard of that. It's used as an ointment, and we use it to treat burns. It's still the most common thing used on burns. Let the patient know that a burning sensation or pain may occur when the med is applied, and staining and discoloration of the clothes and skin may occur. Nursing implications when you're on a sulfa drug. With a lot of these meds, they tell you it's better or more effective on an empty stomach, and this is one of them. But it can be taken with food if serious GI symptoms occur. You should always take it with a full glass of water and drink 8 to 10 glasses of water per day while you're on sulfa drugs. Avoid increased exposure to sunlight and wear sunscreen because it is going to cause the person to be photosensitive. Educate the person about the side effects and when to notify the doctor. For example, teach the patient taking Silvadine that when it is initially applied, a burning, painful sensation is going to occur, and it may stain the clothing and skin a brownish gray. Teach the patient taking sulfasalazine that their skin and urine may appear an orangish yellow color. It's not permanent, though. That will go away. But their soft contact lenses will not be so lucky, and they will probably stain permanently yellow. So wear eyeglasses. Monitor for Stevens-Johnson syndrome and anaphylaxis. Take as directed, finish the full course of the medication, and do not share the medication. The second group of antibiotics are the penicillins. Penicillin was discovered in 1928 by Sir Arthur Fleming, which was a great discovery, but it wasn't used clinically until 1941. I don't know what they were waiting for. The first penicillins used were natural penicillins, penicillin G and penicillin V. When the bacteria started becoming resistant to the natural penicillins, synthetic penicillins were developed. Unfortunately, resistant strains of bacteria to the synthetic penicillins are now common, like MRSA, that is resistant to methicillin or penicillin. Unless the patient is allergic, penicillins are safe and have a low toxicity compared to other antibiotics. Penicillins are bactericidal, and the generic name of a penicillin always contains the suffix -cillin, C-I-L-L-I-N. This makes it easy to identify and remember because we refer to most of the penicillins by their generic name. The abbreviation PCN, which you'll see a lot in my lectures, stands for penicillin. Penicillins work well against gram-positive cocci infections like gonococci, staphylococci, pneumococci, so gonorrhea, staph infections, pneumonia. They treat urinary tract infections, septicemia, meningitis, sexually transmitted infections like syphilis, and respiratory infections like pneumonia. Penicillins are also sometimes given prophylactically if the patient is at a high risk of developing an infection. For example, people with heart murmurs are often put on penicillin prior to dental work or dental cleaning, and people are also put on it prophylactically before and after surgery to help curtail infection. The side effects or reactions to penicillin, again, anaphylactic shock and Stevens-Johnson syndrome. Remember, with all these antibiotics, once a person is allergic to one of the antibiotics, so once the person is allergic to one penicillin, they're most likely allergic to all penicillins or all medications in this category. Also with penicillins, there's what's called a cross-infection. People that are allergic to the penicillins have a higher incidence of being allergic to the next category of antibiotics, which are the cephalosporins. Cephalosporins are another category of antibiotic, but they have similar composition and properties to penicillin. They're sort of like a first cousin to the penicillins. So always use cephalosporins with caution if a person is allergic to penicillin. Superinfections happen often with penicillins. That's the destruction of large numbers of non-pathogenic bacteria, or the normal flora is destroyed so that the bad bacteria can grow. Most superinfections occur in the bowel, and it can be bacterial or fungal. Colitis occurs because of C. diff, and the C. diff causes severe diarrhea, fever, and cramping. Candidiasis can occur due to overgrowth Candidiasis may occur due to overgrowth of a yeast-like fungus found in the vagina. It's usually kept in control by good bacteria in the natural vaginal flora, but the penicillin treating another infection is going to wipe that out, and the yeast-like fungus is able to multiply. And fungal superinfections also can occur in the mouth, around the anus and the genital areas, because the penicillin wipes out the good bacteria. And I'm sure the one you probably have heard of is thrush. Thrush is sores in the mouth, and the tongue looks almost black and furry. And the mucous membranes are bright red. And if you see that in a person's mouth, they probably have thrush. Penicillin can also cause some blood changes, the same as the sulfa drugs, the anemia, the low red blood cells, the thrombocytopenia or low platelets, the leukopenia or low white blood cells, and bone marrow suppression. Penicillin given IM is painful, and most IMs can be. It can also cause phlebitis if it's given IV, glossitis, stomatitis. Those are things from glossitis is inflammation of the tongue. Stomatitis is inflammation of the mouth, and that can occur with PO administration of penicillin. The GI symptoms that are common to all, and then there's the birth control interaction. Some penicillins interfere with the effectiveness of birth control pills. Those would be ampicillin, vancomycin, and penicillin V. Many surprise ampicillin babies were born before this interaction was discovered. So if a woman is in the childbearing years and she's sexually active, you should advise her to use an alternative means of birth control while she's on ampicillin, vancomycin, or penicillin V. Some examples of the penicillins are penicillin G and V. Those are your natural ones. Ampicillin, methicillin, and oxacillin, which are your two drug-resistant organisms, and augmentin. Augmentin is a combination of amoxicillin and potassium. The potassium extends the spectrum of the antibiotic. Nursing implications. Penicillin should be taken on empty stomach 1 hour before or 2 hours after meals, except for vancomycin, Pen V, and amoxicillin. They should be taken with food. A full glass of water when you take them. To reduce the risk of superinfection while taking penicillins, use yogurt, buttermilk, acidophilus, or probiotics. Monitor the person closely for hypersensitivity and allergic reactions. Remember to discontinue right away if Stephen Johnson's or an anaphylactic shock appear. Photosensitivity happens, so they should avoid exposure to sunlight and use sunscreen. Teach the patient about the side effects and when to contact the doctor. Whenever you use a penicillin that's in an oral suspension or a liquid, it has to be kept refrigerated and shaken well before you take it. Oral suspensions are going to lose their effectiveness when they're stored at room temperature. So they won't do you any good. They need to be refrigerated and shaken well. Remember to teach women on ampicillin, vancomycin, and Pen V to use alternate birth control and take as directed. Finish the full course of medication and do not share. The third group of antibiotics are the cephalosporins. The cephalosporins, as I already said, are chemically similar to the penicillins. The generic name of the cephalosporins usually starts with a C. The confusing thing about the cephalosporins is that they're divided into first-generation cephalosporins, second-generation cephalosporins, third-generation cephalosporins, and then within the last few years, they developed a fourth-generation cephalosporin. What does this mean? Did the first generation, the grandparents, give birth to the second generation, who in turn gave birth to the third generation, and so forth and so on? No. And I'm sure you didn't believe me when I said that, but this has nothing to do with Keflex marrying Teflon, which are first-generation cephalosporins, and giving birth to Seclor, which is a second-generation It's much simpler than that. What the generation means is the effectiveness of the antibiotic against gram-positive and gram-negative bacteria. In general, as the generation increases, the medication becomes more sensitive to gram-negative bacteria and less sensitive to gram-positive. Although the definition is becoming blurred with the discovery of the fourth, and who knows, maybe the fifth. So, the first generation cephalosporins are more effective against gram-positive. Second generation are somewhat effective against gram-positive, but very effective against gram-negative. Third generations are more effective against gram-negative, even more effective than the second, but they don't do anything hardly with gram-positive. And then the fourth generation are simply broad spectrum and last longer. They were developed because they have a longer resistance to B-lactamase. Remember, I told you about that when we were talking about superinfection. B-lactamase is an enzyme that's produced by drug-resistant bacteria, and this enzyme destroys the antibiotic and makes it ineffective. So that's why the fourth generation was developed in response to these drug-resistant strains. Cephalosporins work against respiratory infections, otitis media, which is a middle ear infection, and other ear infections, bone and joint infections, and genitourinary infections. The side effects, again, the GI disturbances, the hypersensitivity and allergic reactions, that can range from a mild allergic skin reaction to severe Stevens-Johnson's or anaphylactic reaction. Remember, I know you're sick of me saying it, but if that happens, discontinue the drug immediately. And remember the cross-sensitivity with the penicillins. Any patient allergic to penicillin has a good chance of being allergic to the cephalosporins because of their similar chemical structure. Now, going back to the beginning of this lecture, we talked about the toxicities. Cephalosporins can be nephrotoxic, meaning that they can lead to kidney damage. And nephrotoxicity increases if a cephalosporin is given with another group of antibiotics known as the aminoglycoside antibiotics. And one of the earliest signs of nephrotoxicity is a decreased urine output, so always be aware of that. Examples of cephalosporin, which I again gave you 4 of them, just because I wanted to give you one from every generation. So the first one I have cephaloxin or Keflac, cephalothin or Keflin, first generation, Seclor, which is second generation, Rosafen, which is third, and Durabex, which is fourth generation. So with these meds, with the cephalosporins, you want to take them with food or milk. Teach the patient about the side effects and when to notify the doctor. Monitor closely for allergic reactions and discontinue immediately. Like the penicillins, the oral suspensions should be kept refrigerated. Shake the oral suspensions before pouring. And room temperature, like penicillin, any oral cephalosporin will be rendered ineffective if kept at room temperature. Monitor the person closely for signs and symptoms of nephrotoxicity. Remember I said decreased urine output is one of the first signs, so measure and record the intake and output. and notify the doctor if the total 24-hour urine output is less than 500. Take as directed, finish the full course of the med, and do not share the meds. Hopefully you now have a basic understanding of the sulfonamide antibiotic and the penicillin antibiotics and the cephalosporin antibiotics. I think it is the next three categories that confuse people the most. All of you have known for years that there are many antibiotics, but you probably did not realize they were divided into so many categories. Besides that, the next three categories lump more than one type of antibiotic under the same heading. This being said, take a break, clear your head, and keep in mind that each category becomes a little more potent and a little more toxic than the category we talked about before. So the sulfonamides are less toxic than the penicillins, which are less toxic than the sulfonamides, and so we go on. Take a break and we'll go to the fourth category when we come back. The fourth category of antibiotics includes the tetracyclines, the macrolides, and the lincosamides. These three groups of antibiotics are clumped together because they all inhibit bacterial protein synthesis, which is necessary for bacteria to reproduce. All of these antibiotics are broad spectrum, so they work equally well on gram-positive and gram-negative organisms. Lincosamides are highly toxic and only used for severe infection. So we'd only use them if the penicillin, the cephalosporins, the tetracyclines, and the macrolides are ineffective. The generic name of tetracycline ends with the suffix cycline. The generic name of macrolides and lincosamides ends with the suffix mycin. These antibiotics are used when the microorganism is resistant to the drugs in the previous categories, the penicillins or the cephalosporins. The macrolides are more potent than the tetracyclines, and lincosamides are more potent of the three of them. Remember, the drug of choice is the medication that is effective against a microorganism while being the least toxic. So if you have to choose from this category, you'd first try a tetracycline, then a macrolide. Only use a lincosamide for severe resistant infection. Examples of tetracycline: number one is tetracycline itself. Doxycycline is also a tetracycline. Macrolides, you've heard of these, you've probably used them or been on them too, are erythromycin and azithromycin, which is your Z-Pak. Examples of lincosamides would be clindamycin and lincomycin. The side effects, the GI symptoms, the photosensitivity, the superinfections and the hypersensitive reactions, the Stevens-Johnson and anaphylactic, are also the same as they were for other antibiotics. I do want to say with photosensitivity, the tetracyclines are extremely photosensitive and can lead to a very bad exaggerated sunburn reaction. Also with the tetracyclines, you don't want to give them to children under 9 because they can cause permanent yellow-gray tooth discoloration. Tetracyclines are not well absorbed if taken with things containing calcium. That would be any dairy product or antacid. Also, zinc and iron interfere with the absorption of tetracycline. So you don't want to be on those vitamins when you're on tetracycline, and you don't want to be on a high dairy diet with milk and yogurt. And you want to avoid the Maalox and Melanta when you're on tetracycline. I already said about the hypersensitivity and the superinfections. The nursing implications for this group, the lincosamides, follow pharmaceutical directions for which meds should be taken on a full stomach and those on an empty stomach, because they vary. Always take each dose with a full glass of water. I think so many medications need to be taken with a full glass of water. It's a good idea to make that a practice. I already said with the tetracyclines, the photosensitivity reaction can be exaggerated and severe. It's important that they wear sunscreen and a wide-brimmed hat if they can't stay out of the sun. If the person can avoid the exposure to sunlight, they probably shouldn't be on tetracycline. So if you're a construction worker and you have to work outside, probably this isn't the antibiotic of choice for you. Tetracyclines are taken on an empty stomach, 1 hour before, 2 hours after meals. Avoid dairy products, I already said that, like milk, cream, cheese, yogurt, and ice cream, because that stops it from being absorbed. And also antacids and laxatives, anything in that group, anything that contains iron can interfere with tetracycline absorption. So if you're on those meds, they should be given 2 hours before or after you take your dose of tetracycline. Tooth staining, I already talked about. Don't give tetracycline to a child under 9. And the hepatotoxicity. A daily dose of tetracycline greater than 2 grams per day can be extremely damaging to the liver. So be careful of the total daily dose and watch for signs of hepatotoxicity. Monitor closely for signs and symptoms of hypersensitivity, Stephen Johnson's and anaphylactic. Take as directed, finish the full course of the med, and do not share. The next group, or the 5th group of antibiotics, are the fluoroquinolones and the aminoglycosides. Again, we're talking about 2 groups which are categorized together because they were developed to be effective against antibiotic-resistant bacteria. They are antibiotics which are highly powerful. The aminoglycosides are more toxic than the fluoroquinolones. The fluoroquinolones are broad spectrum. The aminoglycosides are more effective against gram-negative. The fluoroquinolones, the FLQs, are broad spectrum, and they're used for a variety of severe infections that are resistant to other antibiotics. They're bactericidal, and the generic name ends with the suffix CIN. Examples of fluoroquinolones are Cipro, and if you look at the generic, it's ciprofloxacin. Levofloxacin is Levaquin. Maybe heard of both of those. The aminoglycosides are bacteriostatic. The aminoglycosides are bactericidal. They're often used for serious gram-negative infections that are resistant to other antibiotics. They also end with the suffix -cin. Gentamicin, kanamycin, streptomycin, neomycin. The fluoroquinolones and the aminoglycosides are used for a variety of susceptible microorganisms that are resistant to other antibiotics. 2 aminoglycosides given orally, and by this I'm referring to kanamycin and neomycin. These 2 medications are used preoperatively as a bowel prep to reduce intestinal bacteria in order to decrease abdominal infection. And they're given orally to manage hepatic coma. So that's kanamycin and neomycin. The side effects of the fluoroquinolones and the aminoglycosides are the GI symptoms, the hypersensitivity and allergic reaction, Stevens-Johnson syndrome and anaphylactic shock, superinfections, and photosensitivity. I didn't put it. Fluoroquinolones cause severe photosensitivity. It can lead to that exaggerated sunburn effect, just like with the tetracycline. So you've got to be really careful with that. The other thing that fluoroquinolones do is they can cause tendinitis. Tendinitis, and when you're taking the fluoroquinolones, can cause severe tendon pain, inflammation, and it can lead to the actual rupture of a tendon. The Achilles tendon is particularly vulnerable, and when this happens, the tendinitis can lead to long-term disability, and the person may need surgery to correct it. So that's an important side effect that you need to remember about fluoroquinolones. Antacids, iron, and zinc decrease the absorption of fluoroquinolones. Aminoglycosides, go back to our toxicities. They cause nephrotoxicity. So they damage the kidneys. Nephrotoxicity is fortunately usually reversible when the med is discontinued. The probability of developing nephrotoxicity increases. I said this before, so that's important to remember. If you give a cephalosporin along with an aminoglycoside, the chances of developing nephrotoxicity increase. Ototoxicity or damage to the ears leading to hearing loss. Unfortunately, if hearing loss occurs, it is usually permanent. It does not disappear when the drug is discontinued. And also the aminoglycosides are neurotoxic, so they can cause damage to the nervous system. Review the beginning of the lecture for the signs and symptoms of the toxicities. Nursing implication for the fluoroquinolones and aminoglycosides. They can be taken on an empty stomach or with meals. Depends on the med. So you really need to review that. Take each dose with a full glass of water and drink 6 to 8 glasses of water every day when you're on them. Remember that the fluoroquinolones are extremely photosensitive. If taking them, avoid exposure to sunlight and ultraviolet rays. Don't go in any tanning beds. Don't use any sun lamps. The thing with the fluoroquinolones, ultraviolet rays need to be avoided for several weeks, even after completing the course of the therapy. So if a person's lifestyle does not allow for photosensitivity precautions, the med is contradicted. The tendinitis, be alert and mindful of the fluoroquinolones. Teach the patient to report any sign of pain in the tendon, the leg, the shoulder, or the back. Usually it's the Achilles tendon. If they do develop it, they need to rest the involved area, avoid exercise, apply ice, and notify the doctor. Teach the patient on fluoroquinolones to avoid using antacids and meds with zinc or iron because they decrease the absorption. And with the aminoglycosides, be mindful of neurotoxicity and teach the patient what to be looking for. If any of these symptoms are observed, report it immediately. So the symptoms, again, of neurotoxicity are seizures and neuromuscular blockade, which is acute muscular paralysis. Remember, this can affect the cardiac and respiratory muscles and can lead to asphyxia. So review that. The aminoglycosides also cause nephrotoxicity, and the patient needs to learn to monitor their INO, notify the doctor if the output is below 500, check the daily weight, note the appearance and character of the urine, and report any changes immediately. In autotoxicity, monitor and teach the patient to monitor for any hearing loss. A hearing evaluation may need to be done before and throughout the course of therapy because, like I said, the autotoxicity is pretty much permanent and won't come back. The last group of antibiotics I want to talk about are the miscellaneous antibiotics. These are antibiotics that aren't related to one another. They're not related to any of the antibiotics we've talked about. Side effects are specific to the particular medication. And the two antibiotics I want you to remember from the miscellaneous group are vancomycin and Flagyl. And with all of these meds, please read the chapters for more information. Vancomycin or vancomycin is used to treat serious gram-positive organisms not responding to treatment with other antibiotics, like MRSA. It is also used to treat C. diff, and it can be given PO or IV. Flagyl is used to treat serious infections such as intraabdominal, bone, lower respiratory, or CNS infections, central nervous system infections. Flagyl can be neurotoxic, hepatotoxic, and ototoxic. Flagyl should be given with meals and taken with a full glass of water. Tell your patients that Flagyl may cause a metallic taste in the mouth and the urine will become darker. When given orally, Flagyl should be taken with meals to avoid serious GI upsets. The side effects and adverse reactions of vancomycin or vancomycin, all the side effects and adverse reactions of the other antibiotics you're going to see here, the GI symptoms, the hypersensitivity, the Stevens-Johnson syndrome, anaphylactic syndrome, etc. Take it as directed, do not discontinue, and do not share. Superinfections. Vancomycin given IV can cause phlebitis, nephrotoxicity, and ototoxicity. Thing I want to just mention that's important to know about vancomycin, if it's given IV and you give it too rapidly, so your rate of flow is too fast, a very strange thing happens that's known as red man syndrome. So too rapid infusion of vancomycin results in a sudden and profound fall in the person's blood pressure, and it could lead to shock. The reason it's called red man syndrome is because one of the other things that happens includes severe flushing and redness of the head and neck, and it's extremely itchy. So it's very, very important that you do not administer IV vancomycin too rapidly. It should be, each IV dose should be administered over a 1-hour span. So as nurses, you need to monitor the infusion rate and the blood pressure very, very carefully. The side effects and adverse reactions of Flagyl, the same as all other antibiotics. Phlebitis if given IV, neurotoxicity. And another important thing with Flagyl is to avoid alcohol when you take it, and avoid alcohol for at least 1 day after it's discontinued. If Flagyl is mixed with alcohol, a severe reaction occurs. The person becomes flushed, nauseous, vomiting, headache, and abdominal cramping. So it's a very unpleasant phenomenon if you have alcohol and Flagyl together. Just a quick word about the anti-tubercular and anti-leprosy drugs. Leprosy is a communicable bacterial disease mainly seen in the tropics and subtropics. When a person has leprosy, they have peripheral nerve and skin involvement. But with the discovery of an antibiotic known as lamprey and dapsone, 2 antibiotics, leprosy is very seldom seen today. They used to have leper colonies in places where they'd put people with leprosy because of the contagiousness of it. But the anti-leprosy drugs and early medical intervention control the disease and prevent complications. So it's pretty much a non-issue today. Tuberculosis is a communicable bacterial disorder that mainly affects the lungs, but other organs can be affected. Anti-TB drugs are going to be discussed with TB when we do the respiratory unit, so you don't need to know anything about them right now. So this concludes our discussion on antibiotics. All of the medications that we've covered so far are antibiotics. Antibiotics only work against bacterial infections. Remember, all antibiotics should be taken with a full glass of water, and fluid consumption should be increased. Some should be taken on an empty stomach and some with food. Read the instructions before you administer it. All antibiotics can cause Stevens-Johnson syndrome, anaphylactic reaction, and superinfection. Vancomycin can cause red man syndrome. Serious side effects such as ototoxicity, hepatotoxicity, nephrotoxicity, and neurotoxicity may develop depending which antibiotic is being used. We're going to talk more specifically about antibiotics when we discuss specific diseases. I know that this is a lot, and I don't think that you'll absorb it all right away. It's going to take time in your Davis drug guide, but as you start to use these drugs in your clinical setting, you'll become more comfortable and familiar with them. Now, for the brief remainder of this lecture, I'm going to briefly touch upon antiviral, antifungal, and antiparasitic meds. Also, always keep in mind antiseptics and germicides, which are used topically and while cleaning are also antimicrobial agents. The antivirals. There's over 2,000 viruses that can infect the human body. Until recently, there were very few antiviral meds. Immunizations were the only way to prevent viruses. Although immunizations are still the only way to prevent them, because of the discovery of genital herpes, Hep B, Hep C, and HIV, to name a few, extensive research was done in recent years, and the number of antiviral meds has significantly increased. Antivirals work by inhibiting the DNA and RNA so that a virus can't replicate. Because a virus is pretty much, when you just want to put it simply, it's just a clump of RNA or DNA surrounded by a protein shell. And it has to be inside the host to reproduce. These drugs can be toxic with multiple side effects, and they're very expensive. And I gave you a few of them here. Aciclovir for herpes, famciclovir for herpes and genital herpes, Valtrex. Valtrex is the one you see often used for herpes and herpes zoster and genital herpes. And then there's the anti-HIV meds. So you, as a nurse, if you're giving antivirals, watch closely for side effects. Aciclovir, for example, can cause urinary tract problems that look like a UTI, so then you need to drink a lot of fluids with them. Most commonly, antivirals cause GI upsets. And when antivirals are applied topically, the ointments may cause burning, tingling, stinging, and pruritus. And then vaccines are given to prevent viruses. And hopefully we have a new vaccine very, very shortly that's going to treat COVID-19. The antifungal meds. A fungus is just a colorless plant that causes yeast or mold infections in humans. Antifungal meds are used to treat superficial and deep fungal infections. A superficial fungal infection is a skin infection or infection of the nails. And a deep fungal infection develops in an organ such as the lung. Some of the common fungal infections that are treated include vaginal yeast infections, athlete's foot, and ringworm. And you've heard of a lot of these, like monostat for vaginal yeast infections, Lamisil for athlete's foot, Lotrimin for ringworm. The antiparasitic meds. A parasite is an organism that lives in another organism, cannot survive without the host. That includes infectious worms, the helminths, infectious protozoa, amoeba, and insects. Examples of infectious worms are pinworms and tapeworms. Ringworm is not a worm, it's a fungus. An infectious protozoa is malaria. Malaria is spread by insect bites, and it grows in the blood and travels into the organs. Parasitic insects, you all know those, the lice and the scabies. And a parasitic amoeba is a one-celled organism found in soil and water. And so then when you ingest it, the amoeba is going to live in your GI system, in your liver or your intestine. So that's all I'm going to say about antivirals, antifungal, and antiparasitic meds. So read about them in your book. I'm not going to ask any complicated specific questions on these meds. I mostly want you to understand antibiotics and their the nursing implications and considerations. I'm sure your heads are spinning and you probably thought I just was giving you a Latin class, except I was speaking in Chinese. In clinical, you're going to start to see these meds on the MOR. Look them up. See what type of anti-infective it is, what category it goes in. Read about the side effects. Don't try to memorize the names. Just be familiar with the categories, the side effects, and the nursing considerations. You're going to see a lot of antibiotics in the clinical setting. Start to become familiar with them and think about the category they represent. Trust me, it will all start to fall into place. Good night, everybody.